Thank you for joining us for this Conversations in Hematology Oncology. During this segment, we will be discussing key updates on novel therapies in follicular lymphoma published and presented at ASH 2023 in the fantastic city of San Diego. I am Dr. Matthew Lunning, Associate Professor of Hematology Oncology at the University of Nebraska Medical Center, and I am joined today by my esteemed colleague, Dr. Gilles Salz, Chief of Lymphoma Service at Memorial Sloan Kettering Cancer Center in the fabulous New York City, New York. Gilles, it was great seeing you in San Diego, both kind of at the poster session, oral sessions, and then in the evening, kind of walking around San Diego. I know we got a second to talk about what's going on in follicular lymphoma, a heavily trafficked space in clinical trials with a lot of new exciting therapies that have been there, but then are also looking to partner with other therapies. One that comes to mind that I know is near and dear to your heart is tazemetostat. Tazemetostat, has its approval, but now it's looking for kind of a partner to play within the sandbox. Can you maybe comment on your thoughts of what happened in the data at ASH around Symphony 1 and where you think that'll go in regards to Symphony 2?
Well, thank you, Matt, for this introduction, and hello, everybody. Yes, as we know, tazemetostat is a nice single-agent molecule labeled for patients with follicular lymphoma who have relapsed after 2 lines of therapy and have an AZH2 mutation, or who don't have any other options for treatment. As a single agent, the response rate varies according to the mutation of AZH2 presence or not, and it's in the range of 2/3 of patients presenting when the mutation is present, 1/3 when it's not present, and the CR rate is in the range of 10-15%, and the duration of response in the range of 1 year. So it's a good tool, but by itself as a single agent is not enough. So what we did in the Symphony trial was to combine tazemetostat with the classical R² regimen as developed in Augment. What we presented during this meeting was the running phase 2 portion of this trial, where we used tazemetostat in combination with R². In terms of tolerability, we use escalating dose of tazemetostat 400, 600, and 800, and we reached out to 800 without any issues. The side effects were mostly those associated with R², maybe slightly more hematologic toxicity, but nothing major. What was interesting was the response rate in this relapsed refractory population of patients with follicular lymphoma, because the response rate was in the range of 90 to 95% overall for these 42 patients, and the CR rate was in the range of 50 to 55%. What I see this range is because we examined patients that were POD24, patients that presented or not presented the AZH2 mutation, and overall we have the same result. Overall response rate above 90%, complete response rate above 50%. I think this compares favorably to what has been achieved with R² alone, and obviously clearly better than tazemetostat as single agent. What we're moving forward right now is a randomized trial, which is the second part of the Symphony study, where we use R² compared to R² plus tazemetostat. And I will encourage people to enroll patients in this trial because this may bring another options well tolerated for patients. But more to come probably in a few years when we have enrolled all these patients.
Thank you, Dr. Salz. That's a great summary of kind of what's going on with tazemetostat trying to move earlier and earlier. It's hard to have a conversation about non-Hodgkin's lymphoma without, touching on CAR T-cell therapy. Typically the ones we've been talking about most are those CD19 directed CARs. We've seen some recent publications in Blood with 3-year follow-up from the ZUMA-5 trial with axi-cel, continuing to show not only excellent durability from a median PFS standpoint in follicular lymphoma, but also in marginal zone lymphoma. While we didn't see any updated data at ASH on axi-cel, we did see some update 3-year data from the ALARA trial, which I thought was also very interesting with regards to, the durability of that construct, but also perhaps slightly different toxicity profile. Would you care to comment?
Yeah, as you mentioned, CD19 CAR-T have been entering the field of treatment of follicular lymphoma, maybe not at the same speed than diffuse large B-cell lymphoma. Maybe the unmet medical need is slightly different, or I will say even largely different. But we have here agents that are providing to patients a very high overall response rate. Again, we are in the 90% plus, and a CR rate from 75 to 95%, depending on the compound. As you just mentioned, I think we saw the 3 years result of ELARA. Again, I think an overall response rate close to 90%, CR rate above close to 80%. There are a little bit differences in the evaluation of response criteria between trials. We should not do too many cross-trial comparisons. What was interesting was that presented already last year was the fact that patients with a higher tumor burden were unfortunately less responding and have less prolonged duration of response. But with this update, we see that about half of the patients are still in response. I mean, the median PFS is in the range of 3 years. And for those patients that responded, the median duration of response is in the range of 70%. So it's really like some patients have a durable benefit. One of the questions I think that remained open for CAR T-cell therapy in follicular lymphoma is whether they are curative agents or not, and whether, like with other treatment with follicular lymphoma, we will have a slow decline over the years, or if this patient may eventually never relapse. And I think we'll have to wait a long time to see that. But obviously, this has encouraging data. And as you mentioned, this 4-1BB CAR, T-cell nuclear cell, but also lysocell, we had some results with the 2 years update, have clearly less toxicities than axi-cell in terms of neurological event. I will say that the CRS event with patients with follicular lymphoma is not a major issue. Probably this is less inflammatory disease. Patients have less tumor bulk. But obviously, when you have a 10-15% of grade 3-4 neurotox with axi-cell, and you go down to less than 5% with a 4-1BB, even 1 or 2%, I mean, these are more attractive products for patients who usually have not experienced severe side effects for any treatment. So this provides the opportunity to use this treatment in the ambulatory setting. We heard the 2 years update of lysocell, which is not approved yet, but probably might be. And again, now we are dealing with more than 90% CR rate, excellent tolerability. So I think what we have to take into consideration is that there is a competition with the other drug we'll discuss, which are bispecifics. But I will say for 1BB CAR T-cell provides the opportunity to a one-time treatment for patient. And while maybe we have to look at the long-term side effect of this product in terms of immune suppression in particular, I think you get down. I mean, you collect the patient, you get your lymphodepletion 3 weeks later, you get your infusion, you are treated in the ambulatory care setting, and it's done. Within 2-3 months, you get your treatment done. So I think an interesting approach. More to come for sure.
Yeah, no, I think that thematically, and you provided that segue very nicely, is to talk about the CD3, CD20, bispecific agents. I think ASH 2022 was kind of how are we figuring out where to position bispecifics and CAR T-cell, and I think we kind of alluded to maybe it was bispecifics after CAR T and large cell lymphoma. And ASH 2023, we kind of have now this discussion of maybe it's CAR T-cell after bispecifics, but without a lot of data. There was some data, both longer follow-up with not only epcoritamab, but also mosunetuzumab as single agents at ASH, but also some combination data. Perhaps you can kind of talk us through some of the initial mosunetuzumab, kind of longer follow-up data, and then what appears to be partnering fairly nicely with this agent in the clinical trial arena.
Yeah, so mosunetuzumab is obviously, the first one. We have a longer follow-up. The phase 2 data was published, and Steve Schuster presented the 3 years update of this phase 2 data. So I recall very simply, these are relapsed refractory patients, 2 or more lines of therapy for the majority of them, overall response rate close to 80% and CR rate 60%. So really, a very good response to this patient indeed. Tolerability, I think, again, in follicular lymphomas, these agents are well tolerated. There is a few CRS, grade 1, 2, essentially. Even not necessarily in all patients, in the majority of patients, very rare grade 3 or more, and very little neurological event. What Steve Schuster has presented are two interesting things. First of all, it's the duration of response. And at 3 years, it appears that 73% of the patients that had a response were still responding, and particularly those with a CR. So, again, is that competing? Is that cure for some patient? I'm not sure. I think it's too early to say. 30 years ago or 25 years ago, we were not daring to present any follicular data without waiting 3 or 5 years of follow-up. Now we see data early, but clearly they're encouraging. The second thing which I found interesting is that he presented some data suggesting that patients will recover their B cell at the range of around 1 year, like with rituximab, maybe a little bit earlier, and that at 2 years, the majority of them have recovered B cells. So interesting because, we are in an area where infectious diseases are still present, and it's important that we address that with patients. So good data in terms of safety again, and tolerability and duration of response with mosun as a single agent. I didn't think glofitamab is not anymore in the field of follicular lymphoma. We heard some data with epcoritamab, a phase 2 study in the same setting. And, the overall response rate, I think, was 75%. The CR rate was a little bit lower. Maybe this was more difficult to treat patient. Again, cross-trial comparison are difficult, good tolerability. It's a subcutaneous agent, but we know that mosunetuzumab was also developed as a subcutaneous agent. Finally, odronextamab has a more complicated schedule of administration and, very high response rate. Maybe the duration of response may not be as fantastic, but, still we have to work on that. So I think it's, a building theme. Mosunetuzumab is approved and we are using it. And probably like you, I prefer to use mosun before to use CAR-T. The majority of patients, we'll discuss that later probably. Regarding the combination, obviously one of the major partners is lenalidomide, because we heard so much about lenalidomide and rituximab. So this was developed in this field. I think, the data of tolerability are good. There is, again, some rashes and things that we see with len, a little bit more of heme toxicity. We'll expect that. But, whether we gain a very substantial benefit in terms of response rate, it seems yes, we are getting a little bit, but is that really meaningful? I think the question remains open to me. This will be answered by a major trial called Celestimo, which is being performed by combining mosunetuzumab plus lenalidomide. More to come, and this will pave the way for phase 3 trial, comparing likely this combination to standard of care, which will be immunochemotherapy or R-square. I think, this is major drugs in the field, and how they will fit in our sequencing and in different combination remains open.
So you think that biospecifics are going to make its way to the front line in follicular lymphoma?
Well, I think a couple of people have presented data in this area, including mosun or mosun-len. Our group presented the early result of a phase 2 trial of mosunetuzumab in the frontline setting of follicular lymphoma, a CR rate of 73%, patient with a high tumor burden. And I think we have to look at the characteristic of patients in all this trial. And I think this is very encouraging result. So it's just one question regarding bispecific in follicular lymphoma, which is the fact that some patients that fail this treatment lose CD20 expression, and whether they will recover or not, what happens to this patient is a question. But this phase 2 in first line setting are, to a point, very encouraging, and we'll continue to accrue in this trial and probably look for combinations. We heard about combination. Obviously, polatuzumab vedotin is a drug that can be combined with mosunetuzumab. It has efficacy as single agent in follicular, and it will bring another push, another cytotoxic push. We heard some data from MD Anderson using acalabrutinib plus R square, and maybe BTK inhibitor can enter this field because we had thrown them away like 3-4 years ago in the relapsed refractory setting, but now with the zanubrutinib data, they may be entering the field. We have a trial tafasitamab with R square. We have the agents targeting CD47. So more to come. Obviously, the more mature data are with single agent bispecific right now, but I'm sure that combination of more soon or the other bispecific will develop in the near future.
Definitely a lot of clinical trial activity right now, and both relapsed refractory follicular lymphoma as well as making their headway into the frontline follicular lymphoma space. Well, I want to thank you again for joining us for this segment of key updates and novel therapies in follicular lymphoma published and presented at ASH 2023. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios.